I'm told many of you are already doing point of care echo and ultrasound, and some of you are kind of novice new. So I'll try and try and include everything. So if you feel that this is too basic, then maybe we will proceed fast. If there are any questions, any issues, you can put it in the chat box. So in the first 15 minutes, I will talk about basic aspects of ultrasound and modes of ultrasonography. Before we even start doing ultrasonography, probably this is what is going to happen. The traditional stethoscope going to be replaced with handheld ultrasound machine like the one which is shown here in the picture. But with the PCPNDT Act in picture and so many legalities involved, maybe it is slowed down, but sooner or later this is going to happen. Again, this question has come in many open journal forums. So basically, when we talk about ultrasound, what we talk about is sound waves which have a frequency which is higher than human ear to hear and which is generally about 20,000 hertz. And typical diagnostic ultrasound scanners have frequency range between 2 to 18 megahertz. Now the principle of ultrasound, if you look at, there is a transducer which sends ultrasound waves, that is sound waves, inside the body within the tissues, and that happens at a frequency of 10 raised to minus 6 second. So this is the kind of time required to send one impulse, and after that 10 raised to minus 3 seconds. So 100 times more times it waits for hearing the returning signal. So only 1% of the time is spent in generating ultrasound pulse, and 99% of the time it is taken to listen the echo. So the probe actually makes a sound and it waits for patiently for a long period of time to see what is coming back from the tissues. Now there is something called piezoelectric crystal, which has an inherent ability to vibrate and convert electric signal into ultrasound signal and vice versa. So whatever is the reflected ultrasound wave which comes, it converts into electric signal and presents on the screen. And the electric signals are relayed on the machine to process. Now, frequency of the probe is very important in order to understand the image quality, because as the ultrasound wave passes through the tissues in the body, there is attenuation, and its attenuation of the ultrasound wave depends upon the frequency of the ultrasound. So higher the frequency, better is the image resolution, but the lower tissue penetration. So if you have a frequency probe of around 10, 12, 15, 20, then those will not be able to go too deep into the tissues, but then they will give you better resolution for superficial structures. As against if you have a ultrasound or sound wave which has got a lower frequency such as 2, 3, 4, 5, then these frequency probes will have a better tissue penetration, but the resolution or the image quality may not be so good. So for the superficial structures, as a rule, we use high frequency probe, and for a deep seated structures, we use low frequency probe. So this is very basic. Again, depicting here for a 3 megahertz or a 5 megahertz, you'll use it for adults where you want to, the distance from probe to the organs is a little longer or larger as compared to the newborn or pediatric. And if you look at pediatric and neonatal ultrasound, generally 7 megahertz probe is the one which is used. So when you go for a neonatal dedicated ultrasound, you get somewhere around 7 megahertz. And 10 megahertz is something which is used for eyes, peripheral nerves, blood vessels, when you want to cannulate, and even higher frequency probes are also available. So you don't need to remember exactly, but for the newborn, we use 7 megahertz and around. And higher frequency, you will use it for superficial, and low frequency, you will use it for deeper structure study. Now there are different shapes of the probes: sector probe, linear probe, curvilinear, and radial. We will go one by one. Now when you see a linear probe, basically the contact surface of the probe is linear, and because of that, it gives you a rectangular image. Generally, it is a higher frequency probe, and it is good for looking at a smaller area and superficial structures. So sometimes it is referred to as a vascular probe, and this is also useful in lung ultrasound. So a linear probe we will be using for lung ultrasound and vascular access. Now something curvilinear probe, it is a probe where the piezoelectric crystals are arranged on the curved surface. And therefore, these are generally the ones which are used in adult, which have got a low frequency and a deeper structure penetration and gives a wider angle of the view. And the one which is used as a dedicated pediatric probe, which operates around 7 to 8 megahertz, which has got a higher resolution and low penetration, and it has got a small and flat and square contact point, which is known as small footprint, as it is shown here in this particular, if you see this particular probe, this is the probe. And if you look at this probe, it's a small footprint or small contact point. And the importance of this is being the anterior or posterior fontanelle or intercostal space. These are the small sonographic windows, and you want to see inside through these small windows, and therefore you have to have a small footprint probe when you're integrating a newborn baby. Now, these are the probes which are sector probes, which generally generates an image which is a pie-shaped image. And the piezoelectric crystals are arranged in a circle and ultrasound impulse generated in a fan-shaped manner from the center. Now, it has the advantage of requiring only a very small sonographic window to obtain an image. So if you look at this, for the newborn baby's brain ultrasound, we will use a sectoral probe or a dedicated pediatric probe. When we talk about it, it is basically a sectoral probe. That is from one small point, it gives a fan-shaped image, and you are able to interrogate or able to view inside from a small sonographic window. So that is the reason that we are using a sectoral probe in a newborn. Now there are certain points on the body which act as acoustic windows. We know that bone has got very high acoustic resistance, and therefore we are not able to pass ultrasound beam through the bones, as well as air. Air is also a high resistance, and therefore we find places. So anterior fontanelle, posterior fontanelle, temporal window, and masted fontanelle. These are the areas or acoustic windows on the child's skull. And on the chest, there are these four main areas through which we look at the heart. So basically, these are the acoustic windows from which we peep inside. Now, second aspect of ultrasound is what are the modalities of ultrasound. So there are basically conventional modalities and Doppler modalities. So conventional is 2D echo, and M mode is basically motion mode. And Doppler ultrasound is basically continuous wave, pulse wave, and color flow Doppler. Now these two things we need to remember. Basically, we have to remember that all modalities follow the same principle of ultrasound. That is, it sends signal inside the body and waits for the returning signal. They differ in how the reflected sound waves are interpreted by the machine. So so we'll go by one. Basically, 2D mode or B mode of echo, also known as brightness mode or two-dimensional mode. Basically, it gives a cross-sectional image of the area under scanning. So basically, similar to drawing a sketch or a cross section on the paper, and delineates spatial structural anatomy. So suppose this is the heart, and the heart is being cut in a plane as shown here, and the image that what you will get on the screen is shown on the right side, where there is a so it is basically a two-dimensional picture of cutting of the underlying structure. Say for example, in the brain, if there is a coronal section, the underlying brain will be seen as if it is cut in the coronal plane, and you are viewing it from the front. Similarly, in the heart, when you're looking at the heart from the apical view, you will be able to see the heart in the forechamber as a 2D image as shown here. So always remember, in the heart as well as brain, when we do 2D imaging, there are certain fixed points, fixed images that we are expected to obtain. Plus, we are expected to obtain sweep images at every point. There are certain sweep images which are expected, and then they will tell you spatial anatomy, connections, and later on it will help for the flows. Now, basically what to see in 2D imaging, basically look at the anatomy, look at the presence of pathology such as IVH, white matter injury, cyst, etc. In the heart, look for the assessment of the anatomy, chamber size, ventricular contractility. So visual assessment of the heart contractility is also a very important aspect. And any abnormality, if you note, always check it in two different planes to delineate it completely and get it complete picture of the underlying pathology. Say for example, in the coronal section in the brain, you find some bump on the right side in the interventricular area, and this is third image, and here as you can see there is a bump. So here again you take a sagittal view and kind of confirm that that particular bump that you're finding is indeed a grade 1 or grade 2 hemorrhage. Now here in this sagittal section, you're able to see the blood which is there into the ventricular cavity, and therefore it is a grade 2 IVH. If you just go by this image, you would call this as a grade 1 IVH. But then to completely delineate whether there is, because grade 1 and grade 2 differentiates by presence of blood into the ventricular cavity. So if you just look at this, you would call it as grade 1. But then when you look at complete picture, then you know that it is not only restricted into the germinal matrix or caudothalamic groove, but there is some amount of blood which is trickled down into the ventricular cavity. So this becomes grade 2 IVH. Now second imaging is M mode imaging. Now in M mode imaging, there is a scan line, and in that you see the movement of the underlying structures. So it is plotted against the time. So the scan line is plotted against the time. Say for example, here in this case, this is a parasternal long axis view. The M mode imaging is going through the tip of mitral, tip of the mitral wall, and here as you can see, the mitral wall is opening and closing. And this particular moment you are able to see because of M mode. So this is called M mode imaging. Now this is very important for certain parameters that we assess later on. But just to remember that M mode echo can be used for size of the vessels, measurement of the end systolic and end diastolic dimensions of the left ventricle. Basically, it is used to measure. It is basically used to do the measurements and assess the movement, both things. And again, measurements of the vessel size, aortic root or pulmonary root size, ventricular chamber size at the end of systole, end of diastole, SVC, UVC size, their diameter, and therefore it is basically used for measurement mode. Again, to show here, as you can see, the M mode echo is going through the cavity of the left ventricle, and here as the mitral valve opening closing, you are able to get the size of the left ventricular cavity, and this A indicates the maximum diameter of the LV, and this B indicates the smallest diameter, that is the so this is the end diastolic volume and this is the end systolic volume, and then you are able to calculate the fractional shortening in this case. Also, it is used in lung ultrasound. Just to give you, because we want to learn this this thing, so try and get acquainted with these terms. Now on the left side, you are able to see just waves. As against on this side, there are waves, and then there is a sand here, sandy appearance. So this section tells you sandy appearance, and here there are waves, and here there is no sandy appearance. There is all only waves. So if you see something like this, which is there on the left side, also known as barcode sign or stratosphere sign, this is indicative of a pneumothorax. As against here, when there is a sea without shore, so this is sea without shore, and this is a sea shore sign or sandy beach sign, where there is a sand and then there is a sea starting here and there are water. So this is appearance tells you that this is a normal lung and this is pneumothorax. We are going to take this in detail later on, but just to tell you where it is used. Now coming to Doppler echocardiography. Now there are three types: Doppler, color Doppler, pulse wave, and continuous. Basic important thing one has to remember, Doppler is basically used to detect the direction and velocity of the blood within the heart. Now what about color Doppler? It just indicates the direction of the blood flow. Pulse wave Doppler is used for velocities which are lower velocities, less than 2 meters per second. And for higher velocities, pulse wave Doppler is not sufficient. Because not sufficient. So for that we use continuous wave Doppler for velocities which are higher than 2 meters per second. And I've tried to simplify this. So there is something called as Nyquist effect. And in less than in pulse wave Doppler, you're not able to capture velocities which are higher in range. So for a lower frequency, lower velocities, you use pulse wave, and for higher velocities, you use continuous wave Doppler. something called as aliasing or Nyquist effect, which will not go in detail, but simplify for a lower velocity pulse wave, higher velocity continuous wave Doppler. Now, just to highlight this pulse oximeter, so this ultrasound probe is sending ultrasound beam as it is kind of getting reflected from the red blood cells, it changes frequency. So when there is a movement towards transmission source, it increases the frequency. Away from the source, it decreases the frequency. So what is the Doppler effect basically? So the principle of Doppler is that ultrasound waves change frequency as they are reflected from the moving object. So if they are reflected from a moving object, their frequency changes. So if it is reflected from an object which is moving towards the probe, the frequency increases. And if it is reflected from RBCs which are going away from the probe, the frequency decreases as it is shown here. And this is called as Doppler shift. Change in the frequency of the reflected waves depending upon the direction of the blood. So, and the flow which is, and then the machine interprets the change in the frequency, and based on that, it will depict as a flow towards ultrasound probe as a positive flow, and away from the ultrasound beam, it is a negative flow. So below the line, it will show. So now tell me, so this blue flow, what does it indicate? And what red flow indicates? You can unmute and tell. Anyone? So the blue flow tells anybody?
Away.
So blue away, red towards. So the red means that the flow is coming towards the probe, and blue means the flow is going away from the probe. This is not deoxygenated blood and this is not oxygenated blood. Somebody said that this is a oxygenated blood. This is a arterial blood and this is venous blood. This is not correct. So the blood which is coming towards the probe will be seen as a red, and the blood which is going away will be seen as blue. So this is color Doppler. Pulse wave Doppler basically is used to determine velocity of the blood. So here, as you can see, the blue is away and red is towards. So I have put the pulse wave Doppler gate here, and then I'm pressing the button again, and then I'm getting these velocities. Now this tells me the velocity of this particular blood flow is so and so 40, 50 centimeter per second. Or on the red, if we put it, I'm getting the velocity towards the probe. And again, this is telling me that this is giving me the velocity of the blood, which is coming towards probe or going away from the probe. Now there is something called as angle of insonation, which is very important when you are doing pulse wave Doppler. So what is angle of insonation? It is an angle between ultrasound beam and the direction of the blood flow. So just imagine that your ultrasound probe is somewhere here. Okay. Now when the blood is coming towards probe like this. So with a 10-degree angle of insonation, the velocity will come 1.97 meter per second. But if there is an angle, because what happens is that because of this angle of insonation, so instead of here, if the probe is here, you will get 1.97. Instead of here, if the probe is here, the blood velocity is in this direction and the probe is in this direction, and this angle is 30 degree. So with this 30-degree angle, the velocity will be seen as 1.73. And suppose your probe is here and the blood is going in this direction. So if the angle between the velocity of the blood or direction of the blood and ultrasound will be 60 degree, the velocity will be seen as 1 meter per second. So basically, angle of insonation should be less than 15 degrees is an acceptable angle. So always when you're doing Doppler assessment of a blood velocity, then try and align the Doppler beam with the velocity of the blood. If the angle is more than 15 degrees, then the velocity that you got may be erroneously low. But please remember, you will not be able to get erroneously high velocity. So whichever is the higher velocity you get is likely to be the correct velocity. Now coming to the continuous wave Doppler. Basically it is used for high velocities, more than 2 meter per second or more than 200 centimeter per second. Towards the transmitter depicted as positive, away is negative, And it basically in continuous wave Doppler, it is not focused at one particular point as it was in pulse wave Doppler. So basically it assesses along the whole line. So here if you see there is a ventricular septal defect in the parasternal long axis view, you are going to put your continuous wave beam like this. Now you are going to get a velocity of ESD jet which is going to be more than 2. So here it is about 4 or 5. You have to actually measure it. So this looks around 4 meter per second. Now this 4 meter per second velocity is quite high jet velocity, and based on that you can calculate the pressure difference between the two. So again this is a track speed regurgitation, and as you can see the continuous wave Doppler is seen as a diamond here, and then you measure the velocity along the line. All blood vessels, all red blood cells, whichever are going to be aligned with the velocity of the with the direction of the continuous wave Doppler, you are going to get a velocity, and then this is a kind of a negative deflection, and based on this distance you are able to get the velocity and then the gradient. Here as you can see the gradient is 56 millimeters of mercury, and you add right ventricular pressure to it, which is about 5 centimeter. So here you're going to get right ventricular systolic pressure of 61 millimeter of mercury. We are going to see this later on again in PPHN, but just to highlight you where we use what. So continuous wave Doppler is used to identify higher velocities and to understand the pressure difference between the two chambers. So this is modified Bernoulli equation, that velocity of the jet is 4 into velocity square. So the pressure difference between the two chambers is equal to 4 into velocity square. Then just highlight about tissue Doppler. So as we studied about the red blood cell Dopplers or blood related Doppler, so we can measure the velocity of the heart muscle contraction. Tissue signals have higher amplitude and lower velocities than blood. Mitral and tricuspid annular movement is studied, and systolic as well as diastolic function can be assessed. So basically you go in apical 4-chamber view, you press the button where there is a return tissue Doppler, and then this is the tricuspid annulus. So you do you place the tissue Doppler measurement gate here, and press the button and you will get something like this. So again here you will be able to see the velocity during ventricular contraction and velocity during diastole. Similarly on mitral annulus you can do, and this will indicate the diastolic function of the heart. So tissue Doppler is a good modality to understand the tissue Doppler, good modality to understand the diastolic function of the heart. But again, as I said, this is comes into the advanced functional echo, so we will not touch upon this. But something called tissue Doppler is also there that we are doing. So summarizing, basically 2D image is important for assessment, structural assessment of the brain, heart and lung. MOD is important for assessment of moving structures and measurement. Measurements such as valve, annulus, ventricular walls, pleura, etc. Doppler imaging is important to assess the direction and velocity of the blood. And artifacts we have to also remember. And tissue Doppler imaging helps in identifying systolic as well as diastolic function of the heart. So thank you. So are there any questions here?